Good morning, everybody. It's really a pleasure for me to be here and share this lecture with very important speakers like Professor Nankowski and Leonardo Trombelli. And first of all, some greetings from my city, from Milano, where I live and work in northern part of Italy. I think that some of you had the opportunity to visit Italy and our city. If you had not, please do it, because we have so much to offer. It's a nice city, many historical monuments, and a lot of museums to visit, a lot of art, and also some new buildings. We had the Expo, the International Expo last year. We had more than 20 million of visitors coming to our city. And Milano is recognized as the Italian capital of fashion, as well as the economical capital of Italy. And we also have very nice food you can try and you will sure appreciate. Okay, I work in Milano, and I stayed for many years at the University of Milano. In the Department of Oral Surgery and Implantology. My boss was Matteo Chiapasco, that is a maxillofacial surgeon. So I grew up in his unit. Now we do many things together. We share courses, etc. And that was a very important opportunity for me. Now I'm mainly on the private practice, still giving some lectures. And I'm still involved in some educational programs at the university. So coming back to the title of my, to my topic, I will try to show you some possibility to combine enamel matrix derivative with implant therapy, and the possibility to combine mucogingival therapy and implant therapy. I would like to start with a general recommendation. I fully agree with Professor Nankowski. When we do our treatment plans, we should always start thinking about our patients as human beings and try to give them and offer them the best treatment option, providing them a treatment that is based on the scientific evidence, and it's also good from an ethical point of view, because of course, we do our work also to get an economical income, but the economical income should not be the first aim on treating patients. So I think that is a very important part of our work. And I had the opportunity to learn this very important lesson from my parents. They are both dentists and still working in the field. I think that was probably the most important lesson I get from them, okay? So always think about the patient, always respect the patient from the ethical point of view, and try to provide him the best treatment outcome. So the first topic I would like to explore with you this morning is the possibility to combine mucogingival surgery and implant surgery, because we quite often we think about these two different topics as completely separate, but I will show you how we can try to combine them and give to our patients with this approach a better result. We know the risk that Professor Nankowski underlined, and I totally agree, of implants, but we also know the benefit and the potential. And in some cases, in cases like these, we can, I would say today, we cannot think about a treatment plan without implants, because that's the truth, okay? We cannot rehabilitate correctly patient that has lost some teeth without implants. I think that's the option the first option that we should think about today. Okay, and we know we can give them a good result in terms of the possibility to restore the function and the aesthetics of our patients. Of course, implant therapy is only a part of therapy. We'll also do some teeth-supported restoration, crowns and veneers in this case. But implants give us the possibility to completely restore the smile and also the way this patient is smiling and is interacting with other people. Because think a patient that has this kind of smile, this kind of aesthetic problem, how she can be comfortable in speaking and smiling with other people, okay? So despite we work in a very little area of the face, because the smile is only few centimeters, changing with these little centimeters, we can give a completely different light to the entire face of our patient. That's something I really like from my work. Okay, so implants, we know the risk, but we also know the big benefits in some cases, and we also know the potential of mucogingival surgery, okay? Because we have a very powerful instrument in our hands if we're able to manage this. And we can, in a really advanced case like this, look, we have recessions that are probably more than 10 millimeters deep and high. Also, in advanced case like this, of course, we cannot do this in only one step, so we need different mucogingival surgeries, but we can completely change the architecture and the appearance of the soft tissues of this patient, okay? So this is something that is really able to benefit our patients, okay? So we can completely change the appearance of their smile and of their face. And there are several systematic reviews of the literature in this field that are giving us support in to these techniques. We also know that patients are coming to our practice and they ask us to treat these patients because it is, once again, two recession defects that also become an aesthetic problem, okay? So I think as dentists, as practitioners, we should be able to give an answer to patients that come to our practice with this kind of problems. And mucogingival surgery is the way to treat these problems and to give our patient an answer, be able to provide them a solution for these patients. So I think that at least basic mucogingival surgery techniques should be part of our background, okay, in daily practice. So I can show you many cases. What I would like to say is that we are able to give an answer to the patient's problems, to improve the aesthetics, and to reconstruct the soft tissues. Mucogingival surgery is based on a flap design, so somehow we will design our flap. Then we will elevate this flap with, in some areas, partial thickness, in some areas, total thickness. I will show this later with a couple of videos. Then we need, of course, to move this flap, so to achieve a tension-free suture. And then we can treat mechanically and chemically the roots. And prepare a recipient site where the flaps will be repositioned, so that what we usually achieve with a de-epithelialization of the anatomical papillae of the patients. And then we can empower the healing capacity by means of local modifiers of the healing. The enamel matrix derivative has been proven scientifically to act positively in this field, but we can also use connective tissue graft or, more recently, propose the collagen, the collagen matrix. Okay, so that's one recent systematic reviews that was the result of the working group 2 of European workshop on perio. Leonardo was involved in the group, and you see the result is scientifically evidenced. The addition of EMD underneath a coronally repositioned flap is able to improve the outcomes in terms of complete root coverage. So we have scientific evidence in that sense. And of course, we also know that we can use connective tissue graft. It's another techniques. Both techniques are both useful. And that's the 20 years systematic review of the literature that Professor Nakowski cited earlier. Remember that's also the title of this meeting, the true periodontal regeneration. Today we can achieve only with, enamel matrix derivative is nowadays still the only chemical device we can use to achieve the true periodontal regeneration. That means new cementum, periodontal ligament, and other bone inside the periodontal pocket. Okay, and then at the end we will, of course, we will fix the flap in the new position, in the final position with some suture. One implant was placed there. We'll design our flap. In this case, it's a triangular flap. So this surgical papilla will be elevated partial thickness, and in the more apical area, we will go for full thickness flap elevation. Of course, we need some skill. There is a learning curve, like in every field of dentistry. You need to use small surgical instruments and to be very delicate. But not a very difficult therapy. Of course, everybody needs some training, but it's not difficult, I would say, to achieve a good clinical efficacy in this field. Okay, so we will elevate the flap. In the apical part, we will go partial thickness. That's the part that will allow us to move coronally the flap. And then we'll go for mechanical treatment, planing with a small correct the roots. Then we will use the ADTA to condition the roots. The anatomical papilla will be de-epithelialized like this. And then the ADTA is able to expose to remove the smear layer and to expose the collagen fibers of the roots. And then we will place the endogain that has been demonstrated to improve the rate of real new attachment on the roots. So the benefit will be having a real reattachment instead of long junction of epithelium. And that's how it looks after, after treatment. So the implant was in the first premolar position, then had one crown supported by one natural tooth. And that was the treatment plan, because what I want to underline is in many cases we do not need only one technique, but a combination. So this case was treated with orthodontics, with implants, with mucogingival surgery, etc. The final result is always to achieve a very satisfied patient, smiling, and really comfortable with her smile. So, like I was saying before, we can use the enamel matrix derivative, but the connective tissue graft has also been proven to be very good from the clinical point of view. But, there is a but. When we need to treat a patient like this, okay, that has 24 recession defects, how can we think to use in all defects the autogenous tissue from the patient? I mean, can we use 4 or 5 times the palate to harvest connective tissue? So there are cases, complex cases, where we do need to have something like endogain, for example, to improve the healing capacity of the patient. And we also need to treat this patient because she asking to improve her aesthetics. Okay? So in these cases, many different techniques were used, but we also use the endogain in some areas to improve the periodontal healing. Okay, it's not a perfect case, but we achieved the main goal of treatment, that was satisfying the patient. She was complaining for very sensitive exposed teeth, and now I would say the problem has been completely solved. And that's how she looks after treatment. So that was before, after. You see the improvement, the general improvement of the appearance of her smile. And once again, I would like to have a satisfied patient at the end of treatment. Okay. We also have the possibility nowadays with surgical techniques that has been designed for that, to treat multiple adjacent recessions, like, for example, with Giovanni Zucchelli technique and Giovanni Zucchelli and Massimo De Santis. You know, I really like these techniques. I think this really gave some new input in the field of mucogingival surgery. And the principles are the same. We design a flap, in this case with these tilted incisions. We will eliminate tensions and muscle insertions from the apical part of the flap, enable to move the flap. And then we will go for mechanical treatment of roots, deepitalization, and then we will apply once again the ADTA and the enamel matrix derivative. Everything is placed coronally, fixed with sutures, and once again, smiling, satisfied patient at the end of treatment. That was before. You see these very deep recessions, and after treatment. So we really have a very important instrument in our hands. That's a tooth that has a very similar situation to the one that Professor Nankowski was showing. Okay, in this case, fortunately, we do not have an interproximal defect, but we have a deep buccal problem, and you know, we have an additional problem that is related to the buccal position of the root. Okay, so this is probably the most difficult cases to treat with mucogingival surgery. But also in this case, we can, for example, we can think to use a laterally positioned flap. That is another option in mucogingival surgery. And this part will be de-epithelialized and will act as the recipient site of the flap that will be moved in lateral position. And since we need to harvest the entire periodontum of the adjacent tooth, we will not leave this exposed. We will use a small connective tissue graft to treat the exposed roots at the adjacent tooth. Because these are probably the most difficult areas to treat. You see how the root is placed, displaced buccally. Look. So we have lost at least 10 millimeters, and we have 4 more millimeters of loss of attachment in the due to probing in the buccal part. Okay, so we will design our flap that will be moved laterally. Okay, the same principles are used, so the flap is elevated in some areas, partial thickness, in some areas, total thickness. This area is very rich in terms of muscle fibers, so we can eliminate the more superficial muscular fibers in order to help us to move the flap and have less retraction during the healing phase. So that's the part that will be de-epithelialized. It starts to appear the calculus on the buccal part of the root. The defect is reaching the apical area of the root. And I think in this defect where the root is buccally displaced, I think it's very important to use the enamel matrix derivative because we can hope to achieve some migrations of cells from the sides. And again, in these cases is probably something that can help us to achieve some more regeneration, because the defect is very difficult to treat. So we apply EMD on the root, then we will suture the root, the flap in the new position, and at the very end we will treat this area of the adjacent tooth with a small epithelialized graft. Okay, we'll cut a little bit. Okay, and we harvest some a very small graft from the palate. We eliminate the fat tissue, and we fix the small graft in the other part. So, and we could not use a free gingival graft on the exposed root to treat a case like this, because that would be for sure will not be successful. Okay, so we use here the benefit of having a pedicle flap that is carrying his vascularization on the most difficult areas, and we will have a small free gingival graft in the areas where we will have the best option to have its integration. Okay, and then we give the final sutures. That's not so interesting. And that's how it healed. Okay, it is not a long-term healing, but because I treated this patient during a course, and then I missed the possibility to provide the long-term follow-up, but the tooth is still there, and we had a very nice healing. thinking that we had a very deep recession before treatment. Okay, so can we now combine mucogingival and implant therapy? Because there are many cases like this, for example, where we need to place an implant and we have recession at the adjacent teeth. So can we think to utilize a technique that is able to give a solution to both problems? And I think it's possible because, for example, a case like this, we need to replace the first premolar and we have a recession that has an aesthetic impact on the smile of this patient. Okay, so we can think to a flap design that will give us the possibility to achieve a surgical access to the area. We will place our implant, we will do our guided bone regeneration in this case, and at the very end of surgery, we will treat mechanically and chemically the root. We will deepitalize a small part, so it's not a huge changement of our surgery. Okay, it's maybe 5 minutes more in our surgery, but with this, so the flap will be repositioned coronally at the end of surgery. Doing this, we can treat two problems in the same time. So we will do our GBR. And that's how it looks after treatment. So we had our implant, and we also improved the mucogingival architecture of the adjacent tooth. You see, before and after treatment. And it has an aesthetic impact on the aesthetics of the smile of these patients. Okay, there are many cases, because if you start to think this way, you will realize that in many cases we need to place a couple of implants, and we have a mucogingival situation that is what we do not like, and we would like to improve at the adjacent tooth. Like for example, in this case, we have a almost completely lost keratinized tissue, and at the canine, where we are planning to do a crown, and we need to place 2 implants in the adjacent area. So once again, can we think we can use a combined approach, okay? And look also how the level of the soft tissues is different from the lateral incisor and the canine. So the deal was, in this case, to do mucogingival part. So it's like we have 2 compartments in the same flap. So the mesial part of the flap is elevated partial thickness, and we will place our implants. But at the end of treatment, before giving suture, I will harvest from the palatal part of the flap a small connective tissue graft. I will stabilize it with sutures to the roots, and I will cover it completely with the moved flap. Okay? And doing this, I can provide a better solution and a better outcome to my patient. Okay? That's how she looks after treatment, and look how the architecture, the thickness of the soft tissues had a huge improvement. So we are even able to provide a better prognosis to our crown when we create thicker tissues, and thicker tissues, remember, always are more stable during time. Okay? That's before and after treatment. Big improvement, and you see how we also achieved a less different level of the soft tissues between the lateral incisor and the canine. That's a case I showed you before. So there is, it's 3 problems. We have a small horizontal defect that in any case we would like to treat. We need to place an implant, but we have 2 recessions on the adjacent teeth. Okay? Of course, we can do fillings because the patient is complaining for sensitivity. but doing fillings, we will not change the architecture of the soft tissues. How could we think to change this a little bit? You can place the implant. That's probably the most easy part of surgery. And then we will tunnelize this area. And inside the tunnel, we will place a connective tissue graft that has been harvested from the palatal side of the flap. So once again, we do not need, in any case, to be a real second surgical site. We can use, in many cases, only the palatal side of the flap. Okay? Then, of course, the tissues are coronally repositioned. And so in this case, it's implant placement plus tunnel plus connective tissue graft. But at the end, it looks completely different than it was before treatment. And in the same time, we treated the horizontal defect only by means of the connective tissue graft. Okay? So we have our implant-supported crown. We have treated the horizontal defect. And in the same time, we also improved the architecture of the adjacent soft tissues. Again, here we have three problems. We have the horizontal defect. We need to place one implant. And we also have a pocket with some probing in the mesial part of the second molar. And we also have some recessions on the adjacent teeth. So can we, again, think a surgical techniques that is able to resolve the recessions, the horizontal defect, the periodontal defect, and the implant placement? I think we can do this. And in this case, enamel matrix derivative was used on root and inside the periodontal defect that has a small vertical component, infrabony component. And we used a connective tissue graft just to treat the buccal defect. Okay? It's exactly the same case.
She work it, girl, she work the bowl, she break it down, she take it low, she's fine as hell, she's about the dough, doing the thing right on the floor and mon making. Look at the way she's shaking, make you wanna touch her, wanna taste her, have you lusting for her? Going crazy, face it.
The probing is easier to the second molar.
Just how to move, seduce you. She's gonna do the right thing, touch the right spot, dance in your lap till you're ready to pop. She's always ready.
So in the mesial part, we think mokug'jinjibel, and we think to design a flap that will be repositioned coronally at the end of surgery. Then a traditional flap is used for the implant component, let's say. And the mokug'jinjibel principles are used to elevate the flap in its mesial part. So we go mainly partial thickness here. Look how thick is the palatal flap. So that's the part where we will harvest some connective tissue. And the roots are planned as usual. Set sheets. When you're ready to ride, I'll be ready to roll. I'll be in this bitch till the club close. What should I do in all fours? Now that shit should begin to law. Different style, component of the infrabony component of the defect. We will also try to smooth a little bit the amalgam that will be renewed after surgical treatment. Big thickness of the soft tissues. Then we go for implant site preparation very shortly. That is not the interesting part of treatment. Then we harvest some connective tissue from the palatal part of the flap that is very thick, like I told you. So that's a very easy way to get some connective tissue. And we will go now for chemical treatment with a DTA of the roots.
She's so much more than you used to.
That is leave to act for 2 minutes, as usual. Then in the mucogingival part of the flap and in the periodontal part of the flap, we will use the enamel matrix derivative to improve our healing. We will also use a small bone substitute, a small graft of bone substitute, bovine bone mineral. The small part of the graft we also use buccal to improve the shape of the ridge. Okay. Then the graft will be sutured on the buccal flap. The adjacent papilla will be de-epithelialized as usual.
In a fantasy, it's plain to see.
So the graft now is fixed on the buccal flap.
From the couch to the counters of my kitchen.
So we start externally, we go to the connective tissue graft, and then we come back in the same direction from the graft outside from the flap. Then we will use the final sutures. So let's go to the final result. That's how it looks after treatment. It was before, like I told you, we also changed the old amalgam restoration in the adjacent teeth. See that how also the horizontal defect has been nicely treated. Okay. And then we have a last possible application of mucogingival surgery to implants. That is like Professor Nankowski told, the possibility to treat aesthetic complications. And I fully agree with Carlos, it is not easy to treat, but now in some cases we have surgical techniques that give us the possibility to treat these aesthetic defects, okay? And it is an emerging problem because implants are used more and more, even when they are not the right solution. They should be used after some years, after trying to treat periodontitis and to restore teeth. But in some cases, we will have this kind of aesthetic problem. So I think nowadays we also have some surgical solutions for these problems that are more and more representing a problem. Like, for example, again, the Giovanni Zuccalli technique that works very well in treating this problem, but it is not the only solution. In many cases, we need to, first of all, we need to change the shape of the abutments, so to transform the abutments from an horizontal finishing line to a vertical finishing line, because this will give more space for the connective tissue graft and for the soft tissue healing. Looks how it looks better after the simple changement of the shape of the implant supported abutment. And then the Zuccalli technique is not the only one we have, because I like to use in many cases the tunnel technique. So the tunnel, since here we don't need to really change the apical coronal position of the soft tissues, we only need to get a bigger thickness of the soft tissue to cover the grayish color of the implant. We will create a tunnel and we will pull a small connective tissue graft inside the tunnel. It is not the same case you have seen in the pictures, but it's a very similar case. Same problem, you can see. So we remove the crowns and we designed this coronary reposition flap. It is the same design that we can use on natural teeth. So a very simple trapezoidal flap, square flap. Same principles, partial thickness flap elevation. We need to achieve a good recipient bed for our connective tissue graft, so we try to leave the periosteum and some tissue that will be very important in revascularization of the graft and of the flap, that will be coronary reposition. So as usual, we need to eliminate tension from the apical part of the flap to be able to move it coronally. Now the flap is free to move, but we can again eliminate some little part of the muscle tissue from the very apical part of the flap. Then sometimes we can achieve some more space and a smoother surface of the implant. So we will use some burrs to achieve full decontamination of the implant. We take measures because in order to harvest the correct size of the graft. And in this case, we will use a little bit thicker graft, okay, because we need some thickness to cover the implant. So compared to usual mukogingibal surgery, we will go a little bit deeper with our graft. So in these cases, it's important to protect the palate during healing with a very thin retainer. Okay, it's very like an Invisalign retainer. You cover the palate, and that will improve a little bit, really a lot, the healing. Again, small instruments. We cannot do this kind of very delicate surgery with big instruments, big retractors, big blades. You've seen the sushi technique to eliminate the epithelial layer. I've been to Japan to learn this technique some years ago. Because, of course, the epithelial layer must be eliminated completely. And now we are fixing the connective tissue graft with some very small sutures. 6 zeros, 7 zeros sutures are usually used in this case. And now you will see a nice profile view of the case where you can really realize how we are able to recreate kind of a root convexity at this side. Because one of the problems of implants is we do not have the root. You see how the graft is able to recreate a graft, and then the flap will be sutured to cover the connective tissue graft in the final position. Okay. Now let's come back to the case I was showing you just before. You see how the shape of the soft tissues is changing dramatically before and after treatment. So now we have a very thick tissue, a very stable tissue. I will not expect this tissue will suddenly retract in the following years. I want to create a very stable situation. And then I will go for new crowns. And that's how the patient smile looks after treatment. That was before and after.